Well, hello everybody.
Hello.
We'll go ahead and start with our review first of the lecture that you guys listened to before class. So on this slide, we really want to make sure that you guys know the differences between the 4 different types of hypertension during pregnancy. One to point out especially is the gestational hypertension. So please note that that one is set after 20 weeks gestation. So you have to be past that in order to be in gestational hypertension, and it can last up to early postpartum period. And the main cure for that is birth. They can be managed, but it won't be cured until after the baby is born. And then there are lots of risk factors listed here. They are important to know, but one thing I really want to point out to you guys is that you could be 100% healthy. You could be a marathon runner, have absolutely no past medical history, and still end up getting preeclampsia in pregnancy. It is directly related to pregnancy. And then on this slide here, the main difference thing to remember about preeclampsia is that in addition to hypertension, you do need to have proteinuria. So you have to have some kind of protein in your urine in addition to the high blood pressure in order to be considered preeclamptic. And as a reminder, preeclampsia is the before seizure phase, right? Because eclampsia is when you are seizing, and preeclampsia means that all of these signs are trending toward you may develop a seizure. We did keep this here just so that we could talk about it. Edema used to be part of the diagnostic criteria for preeclampsia. However, it is not anymore because it was not exclusively seen with preeclampsia. However, it is very, very common with it. So please make sure to note that. Please make sure to assess that and know that it's possible to see it with it, but it's not necessarily diagnostic. And then here I want to note that there are the different ranges here for how high your blood pressure will look when it's preeclamptic. And the book does directly mention that it has to be taken at least 4 hours apart. And the reason they set a standard for that is because, I don't know if this has ever happened to you guys before, it's definitely happened to me before. You go into the doctor's office, you're running late, you're stressed, you have a lot of questions, you don't know what's going on, whatever it is that's happening, and your blood pressure is high when they first assess it when you walk right into the clinic, right? So we just want to make sure this is actually consistent, that is what's happening with their heart, that they are actually hypertensive consistently, and that means that they are preeclamptic. And then there are multiple ways that you can test for the proteinuria. One of the most common ones is the dipstick test. It's probably the quickest, but know that there are other ways that you can test for that and know what they are. And then again with the edema, a lot of pregnant people have edema, right? So one of the biggest things to note with that is weight gain. Always know what your normal ranges are, depending on where your patient is in their pregnancy. And then know that with that, if you do see severe edema and weight gain, again, antennas up, you could be in preeclampsia. This chart is super, super important. Please memorize this chart. Don't forget this chart. Know all the things about this chart. The blood pressures, the differences between mild and severe, and all the effects that come with each of those, including what happens to the placenta, to the fetus, and the signs and symptoms to be monitoring for, and the effects and why they're happening are all on this chart. So please make sure that you know that one.
The deep tendon reflexes, they become hypoactive, correct?
When they're preeclamptic, correct. Yep, so that's going to be in one of our future slides. You are correct.
Any time they go down though, so we're looking at like +1, does that rule out preeclampsia?
I would say if it's abnormal, we got to know why. That's what I would say. So we need to look at the scenario to figure it out. But anything that's going to be above the +2, +3, or +4 is going to point you toward that they're probably preeclamptic.
Okay.
And then this has the slide showing you how to test for them. One thing that I really want to point out is that normally there should be absolutely no clonus in anyone. If any of you guys put your feet up right now and I tested you for clonus, it should not be present. So if you do see this, note it is very, very important to note because you're probably in preeclampsia. You are in preeclampsia if you have this essentially, because this is going to be one of your big telltale signs that eclampsia is on its way. So please assess for this when you're doing your DTRs, and please note for testing purposes as well that this is a major sign of severe preeclampsia and eclampsia to come. And then here's that chart that you were just mentioning a second ago. So anything that's going to be +3 or +4 is going to be at our risk there. And then,
One thing.
yeah.
So Cole, to add on to
Yeah.
your question, if you stay on that slide, that'd be great. So any elevated DTRs would obviously be a sign that they're preeclamptic. So that slide that Crystal talked about, that emphasized memorizing it, the differences between mild and severe. So basically all you need is around like 1 or 2 signs from the severe category to bump them to severe. So they could be, their blood pressure could be hanging out at 140/90, they could have +1 protein, but as soon as they say, yes, I do have spots in my urine, or in my urine, in my vision, or I do have, I don't know, epigastric pain. Even if their DTRs are normal, it's only if 1 or 2 symptoms of the severe category that makes them severe. So that's like super important. So that's why if someone comes in with like we call it like a PIH workup, pregnancy-induced hypertension workup, and we're ruling out preeclampsia, we have to ask them every single one of those questions, because not everyone will have a headache, or not everyone will have elevated DTRs, but they will have 1 or 2 of those symptoms at least, and that's what bumps them to that severe diagnosis. Yes.
So just to understand, so the diagnosis of preeclampsia is based on blood pressure and proteinuria.
Yes.
Then, once you get into that diagnosis, then you use edema and deep tendon reflexes and blood flow to the fetus to diagnose mild, severe, or eclampsia.
Correct.
Is that accurate?
Yeah.
And one symptom in the severe column can bump them into severe?
If all of a sudden their blood pressure, was 140/90, they had just +1 proteinuria, but they had that headache that was unrelieved by Tylenol, boom, severe. So it just takes 1. So that's why it's super duper important to just know. This slide just really shows you that progression of the disorder, and it just will keep getting worse. That's why we have to be very proactive with our treatment and our plan of care.
Awesome. No, thank you so much for clarifying. All right. Yes, and then management of mild versus severe is also going to be important. So not only knowing what the differences are, but knowing how you're going to manage that from these slides is going to be important as well. And then I think we have, some for the severe as well. So know what you're supposed to do, what you're supposed to assess for, what kind of interventions to expect. And then these medications, so you guys went over antihypertensive medications before, so these will not be on your test, but it is important to know them. I'll come back to them in just 1 second, but the very first line treatment when you are admitted to the hospital for preeclampsia is going to be your magnesium sulfate. However, sometimes if you still need extra management in addition to that, they may add on one of these oral antihypertensives as well. But for testing purposes for this class, you do definitely want to know magnesium sulfate, everything with it, rates, flows, all that stuff. And then definitely also know how to assess. Oh yes, go ahead.
Sorry.
No, go ahead.
Just back to the medications. If they were just saying like the mild preeclampsia, would they ever just use one of these medications and not use magnesium sulfate? Or is magnesium sulfate like always first for preeclampsia?
Magnesium sulfate is always going to be first line for preeclampsia. Yeah.
Thank you.
But they could be managed if they're in the
If they're in the hospital. Yeah.
Yeah, if they're at home and they're managing their mild preeclampsia, they could just be on the hypertensive medications. But once they're in the hospital and they definitely have severe preeclampsia, we need to give them MAG.
Okay.
For sure.
Thank you for clarifying that. Yeah, good question. And then, oh yeah, so management of magnesium, if it's too high hypermagnesemia, make sure you know what to look for and then what you're going to do if you do have those symptoms. How often you're supposed to be assessing, what the goal is and everything. And then again, we're gonna be assessing our DTRs about at least every hour, if not more frequently. And then the treatment, again, for hypermagnesemia, outside of stopping the drip, which is going to be your first line action, is going to be to give the antidote, which is the calcium gluconate. So all of these measures, again, are to prevent them from reaching eclampsia, which is a seizure. So please note what this looks like. Please note what you're supposed to do for it. Normal seizure interventions, as always, safety with that, and then how it is we're going to treat it in this setting here based on the slide. And also as a reminder that just because the baby was born doesn't mean they're not at risk for developing or for continuing or developing preeclampsia. Most at risk 24 to 48 hours after, but could even progress a little bit beyond that as well. So always keep your eye out for that. And then HELP syndrome, the main thing I want to point out about this is that it is specifically related to preeclampsia. So not everyone with preeclampsia is going to develop HELP, but you cannot develop HELP without preeclampsia. So it is one of the side effects of preeclampsia. Not everyone will have it, but it is a possible. Know what it looks like, know how to identify it, know what you're going to do for it, and how to manage that as well. And that's it for our overview. What other questions do you guys have?
For the clonus, like, are you expecting the leg to drop when you support it, or?
So you don't want to see it oscillate. That's what you're looking for. So when you have them flex against it, it shouldn't do anything. It should stay as it is.
So when you flex it, it should stay?
It should stay, yeah. It should not move. But
Well,
but Professor Andrews might be able to specify more.
So for clonus, like if you guys were to like, if this is like the leg and you dorsiflex the foot, like if I just flex back your foot, it should just, you know, flex like I would push against your ankle, and just kind of chill and do whatever. If clonus is present, when I push back, all of a sudden it'll start like popping. It's wild. If you guys go on the PowerPoint, then not the narrated PowerPoint, well the link is still on there, but there's a little YouTube link. It did take place in a different country, but it shows a real video of clonus right down there. So if you
fake.
it's
It looks fake.
Like they're faking it when they do it.
But it's just crazy looking.
It is,
Yeah.
yeah, it's really wild. So like, when you guys see clonus, like you should be sweating. You should be like, oh my goodness, they're gonna see. Like I have goosebumps talking about it. Like it's like they are about to seize.
How quickly.
I don't want to tell you like a time that they're like darn close. Like, you need to get MAG on them ASAP because they're gonna seize. If they seize, the placenta's gonna erupt. You're gonna lose a baby.
Would it be like a rapid response situation?
So we don't call rapids or codes really.
Okay. You just,
It's like start the MAG
okay.
ASAP. Yeah, it's scary. You should be sweating. If I'm sweating, you're sweating.
All right.
Her face is sweating.
Run out of the room.
If she's sweating, then I can't do any of that.
Also, are we gonna need to know the parameters for like the normal range for weight gain?
So we should already, yeah, we should know
Like the
that, so you
number.
can know what abnormal is, right?
Yeah. So if it's like, geez, 28 weeks and has gained 25 pounds or whatever.
That's a good question. So Chelsea asked, do we need to know the normal weight gain? And you do need to know what's normal, so you can figure out what's abnormal, right? But how I would phrase it on like a test question would be like the patient gained 4 pounds in 1 week. Is that normal or no?
Abnormal.
It's very much abnormal. So it'd be something like that, but I wouldn't give you like a big picture because
Right.
some people like ice
It's
cream, you know.
over
Can you make all the questions that simple, please?
Good question.
I tried, guys.
Alright. So go ahead and move on to our case study here. So we have a 28-year-old mother who comes into the clinic at 30 weeks gestation for a routine prenatal appointment. She comes in 15 minutes late and tells you her car wouldn't start again. She is G1P0000 and otherwise has no significant past medical history. The certified nurse assistant obtains vital signs and gets a blood pressure reading of 153/95. The CNA alerts the nurse. What is the patient most at risk for having? Preeclampsia. Good job. And I'm going to ask you this next. What factors puts her at risk for that? Blood pressure. First pregnancy, right? 30 weeks, right? Because how many weeks do they need to be in order to be in the preeclampsia category? 20, exactly. So the patient was sent to L&D triage for pregnancy-induced hypertension workup. The provider orders the proteinuria dipstick test and vital sign assessments every 15 minutes. The nurse is presented with the following data. Highlight the findings that would require immediate follow-up. I'm gonna give you guys about a minute to look at this chart and then we'll go over it together.
She's a Nola Para, right? Or Nola? Nola Para? Or Primapara?
This is her first baby. Should be premature.
Like that.
Yeah. I'm more,
I'm just gonna give people a little bit longer to look at it. We had a question back here, yeah. You were gonna answer? All right. Give it a couple more seconds here for people to look at. All right. So we'll go ahead and go over each category together. So in the vital signs, what are we most worried about? The blood pressure. Good job. And then what about our urine test? How does that look? Okay, how much protein should they have in their urine? Zero, exactly. So anything in there is going to be of concern. And then how about our cardiorespiratory assessment? Right, and so remember we said that we do want to note the edema because we want to know if it's a very severe change or if it's a sudden change, that she could have potentially had edema before this, right? But I'm glad that you guys picked it up because it is something we want to pay attention to. And then how does our obstetric picture look?
Fetal heart rate.
Maybe, but I think this is, we'll tell you this is stable for this baby. And then how about the neurologic and musculoskeletal assessment?
Visual.
Or is it no complaints of any of them?
Right, so there are no complaints of any of those symptoms.
Yeah. That's awesome.
Oh, wait.
Yeah.
Yeah, so we don't have any complaints of neurological and musculoskeletal issues, so that area looks okay on assessment. And then how does our fluid and nutrition status look?
Good. Just fine.
Awesome, because she gained how many pounds since her last appointment? And she should only gain how many per week at this point? 1 pound, exactly. Like we said, we should know that, so just remember all your information there. Alright, now based on that, which of the following assessments indicate a risk for mild preeclampsia versus severe preeclampsia? For each patient finding below, click to specify whether findings are consistent with the diagnosis of mild or severe preeclampsia. I'll give you guys a little bit of time to look at this as well, and then we'll go over each one. Okay, let's go over this first one here. For this blood pressure, do we think this is in the mild category or the severe category?
Mild.
Mild, right. And why is it in the mild category?
Not 160.
Not quite 160 yet, right. And then a headache. If she did have a headache, which one would it be?
Severe.
Severe, right? Because any neurologic symptoms, we want to be watching out for the severe category. How about shortness of breath?
Severe.
Okay, severe. Why severe? What causes that?
It could be the fluid.
I think someone said it over here, pulmonary edema, exactly, fluid, yep. And then how does her DTR look?
Well, no, it looks normal, so mild.
All right, there you go. So if there's no problem with it, then she's still in the mild category. And then what about the +2 urine?
Mild.
Mild. What would make it severe?
After 2 dipsticks,
+3, right, consistently +3, exactly, or greater. And then how about visual disturbances?
severe.
Severe, good job. Based on this diagnosis, so all of these, we said she had the blood pressure of 149/93, she had normal DTR, and she had +2 protein. So based on what those categories meet, she's mildly preeclamptic, right? So should the nurse expect the provider to recommend hospitalization?
Yes.
No.
I hear some yeses and I hear some no's. Well, anyone that said yes, can you give me an answer why you said yes?
I'm saying yes because she needs to have the baby born and she needs to be monitored in case because she is at a potential for reaching a seizure.
Okay.
So I would say yes.
Yeah, I think those are some good thoughts. How about anyone that said no? Why are you saying no?
Have like other kids at home that she has to care for, so she should be able to do pretty much bed rest at home unless her symptoms worsen if she's still mild.
Yeah, so that's the right train of thought. So anytime we have the opportunity to get a patient to go home, they're always going to heal better at home than they are at the hospital. So if we can safely send them home and they are able to rest, even if they have kids, right? Because some people still can, they have a lot of support and whatever it is, but it's good to always take that into consideration. So for this patient, we're going to say she doesn't have any extra things in her way. She will be able to manage those symptoms at home, so she can go home. But you are correct that just because you're mild doesn't mean that you're always going to be sent home. So you weren't wrong to say no. It was kind of a both could apply. Because let's say again that she couldn't comply with being on bed rest, right? Like she did have a bunch of kids and no support system at home. She may not be able to stay on bed rest. She may not be able to become medically literate enough to be able to manage her blood pressure at home, like take that, do the dipstick test and all those things. So definitely just be mindful again of, it's not a checklist, it's always what is going on with this patient, but if we can safely send them home in mild, we will. Any questions about that before we move
Really,
forward?
they sent people home with high blood pressure?
Yeah, as long as again they're at that safe mild range. It's not safe, but you're not severe yet. So if you can manage it at home, I guarantee you that when you're in the hospital, you're going to be at 100 more risks for 100 more complications of things. So if they can send you home, they will.
It also depends on gestational age too.
Yeah.
Like what if someone's like 40 weeks on the dot and they have mild preeclampsia? It's gonna be, let's just have a baby.
Right. Yeah.
But if they're 30 weeks with mild preeclampsia, if we can realistically manage it at home, we'll try.
Awesome. All right. So what would this patient's plan of care look like? So I'm going to go ahead and let you guys look over this chart. There are 4 different categories we want to talk about for the plan of care. And I want you guys to select all that apply in each section for what we do want them to do for their plan of care. So take a minute to read that and we'll review it together. So let's go ahead and start with this first section here. In our activity restrictions, which of these do we want to tell her to do?
Bed rest one leg on the left side.
Right. Do we want her to exercise or to work? No, we should not be recommending those. And of course, it's always going to be a multidisciplinary discussion. So certain patients, again, depending on where they're at, what's going on in their life, any other comorbidities, you can always discuss with the provider about what bed rest looks like per person. But ideally, it's going to be bed rest lying on the left side. Why do we want to be on our left side? Perfusion, I kind of heard that a little bit. So what's going to happen if we're lying on our right side? What are we potentially putting pressure on? The vena cava, exactly. And if we're hypertensive, is our vena cava working hard or is it not working much? It's already working hard, so we don't want to make it work any harder than it needs to. So always on the left side. And then how about for our home care assessments? Which of these do we want her to do while she's at home? Daily BP checks, good. Fetal movement, correct.
Daily weight.
Daily weight, yep.
Daily
And then the daily proteinuria dipstick check, exactly. So the other two are not bad things to watch for, but they're not things that we need to educate her on watching at home for herself. Again, things we need to let them know is what could be bad. So if all of a sudden you're not going to the bathroom half as much as you used to, definitely let us know. If all of a sudden you wake up one day and your legs are 3 times their size from the day before, please let us know. But we're not going to ask our patient to assess their level of edema, and we don't necessarily need them on strict eyes and nose and measuring their urine output while they're at home. How about nutrition management? Which of these things do we want her to do? Increase protein, okay, and why would we want to increase protein? Because you're losing it, exactly, and somehow you want to get it back in your body, and nutrition's going to be the #1 way to do that. What else do we want her to do?
Fiber.
Increase fiber. Yeah, why do we want to increase fiber? Straining, constipation. Right, and those are things that she could already have in pregnancy, and what in this plan of care is going to make that even worse? Bed rest, right? She's not going to have that normal motility in her gut to be able to have bowel movement, so increasing fiber is definitely a good option.
And not as much fluid intake as well, because she's having edema, so that's also not gonna help.
Yeah, and I think that's a really good thought with that, is being mindful of not drinking too much fluid because you are at risk for developing that edema. However, she is going to be more hypovolemic, and we do want to make sure she has enough volume in her system. So we actually do want to ask them to increase their fluid intake, not drastically, but make sure that they're drinking enough, get their 2 liters in, potentially a little bit more, but again, keeping an eye on that edema and that weight gain. Do we want them to increase their sodium intake? No, why not? Increase blood pressure, good job. And then which of these tests might she need to do while we monitor her when she's at home? Bi-weekly non-stress
Yeah,
test, and then I
all
think
of
I
them.
heard someone over here say the biophysical profile, yeah.
We not fetal ultrasound.
So we don't necessarily need the fetal ultrasounds unless we had some other concern going on about baby's growth or whatever, but ideally. So anything that's part of the biophysical profile, yes, but just a regular like growth ultrasound assessment, we don't necessarily need any more of those. Unless again, there was something different going on.
And why would you do bi-weekly NSTs and weekly BPPs? Because isn't the BPP like more comprehensive and include the NST in it?
That's an excellent question that I might have to refer to Professor Andrews about, because I'm not as familiar with those tests and why
So-
they would need that frequency.
So just like you said, BPP is more comprehensive, so that's good. That's great. So
Okay.
they'll just get additional NSTs on top of that.
Oh, okay.
Okay.
But you're right, the BPP is ultimately
An NST plus.
NST plus the 4 ultrasound components,
Right.
which will be more predictive of their of the baby's compromise.
Would that be done in severe?
Severe, they're at the hospital.
Yeah,
right?
and
So
will they be receiving all that stuff?
So remember, when they're in the hospital, we would not let them even off the monitor.
Oh,
Okay.
nice.
So, because they're going to be continuous fetal
Yeah.
monitoring. So that's, I mean, you don't get better than that.
Yeah.
Well, all the fetal ultrasounds though, are
So
those gonna increase in frequency?
so once they're admitted with severe preeclampsia, it's like we're having a baby.
Okay.
So it's going to be, let's put them on MAG to prevent seizures. let's start inducing them and having a baby.
Sounds good.
Great questions,
Excuse me,
guys.
Crystal.
Yeah.
On the first category is only bed rest, Miss Check, right? Everything else.
Correct, yeah.
That's what-
Yep, we don't want them exercising, we don't want them going to work or lifting. Alright, so after the nurse educates the patient about the treatment plan, the patient replies by saying, bed rest sounds doable. Now I have an excuse to sit in my recliner and order Chinese takeout every day. But with all my car troubles, I don't think I'll be able to come in twice a week. I barely made it today. What education should the nurse provide to the client, and what recommendations to the plan of care can the nurse suggest to meet the patient's socioeconomic needs? So we'll do one question at a time. Go ahead and read her response there, and then let's go ahead and pick apart what it is we might need to educate to based on what her understanding of the plan of care was. All right. What do we think are some of the problem statements here?
It's not chair rest, it's bed rest.
All right, yeah. What else do we have? Right. Chinese takeout,
High in sodium.
high in sodium. What else might be concerning from this statement?
Transportation.
Transportation, absolutely. So now I have an excuse to sit in my recliner, order Chinese takeout every day, and I don't know that I'll be able to get to all those appointments. So what is it you guys want to do about these? How are we going to help this patient tailor the plan of care toward them so that we can make sure they're able to meet their needs at home? What do we want to do first for, now I have an excuse to sit in my recliner? What can we recommend to the patient?
Can it lie flat?
Can it lie flat? Yeah. I mean, from what I've heard, when you're pregnant, you do anything you can to be comfortable. So if that recliner is what makes her comfortable, if she can lay it flat and then lay on her left side, it's definitely an option, right? So let's try to make sure that she's able to do that realistically. And then how about order Chinese takeout every day? What do we want to recommend for her with that?
No sodium.
Someone said 6
Sodium
grams.
content.
I heard that. Yep. So we want to make sure we're monitoring our sodium content. So we want to stay within 6 grams every day. And then what else do we want to recommend for her about her nutrition?
Fiber.
Protein.
High fiber.
And high protein.
Protein.
Yep. Protein and fluids. Yep.
We need to know, like, the specific, like, amount of protein they need to be getting.
I don't believe that's super important, Professor Andrews, if you want to correct me though. The
I think
specific
it
amount
would
of
be
protein.
good to know what should be included in the plan of care.
There you go. All right, and what do we want to do about, but with all my car troubles, I don't think I'll be able to come in twice a week. I barely made it today. What do we want to recommend? Family who can help her out? Yeah, let's look into what kind of a support system she has.
Community resources.
Bus schedule.
Community resources, bus schedules. What else?
Referral to social work.
Yeah, referral to social work. Loves an interdisciplinary collaboration. What of the tests that we recommended for her might be a better option? The weekly biophysical profiles, right? Because that's only going to be once a week, so we can offer her that instead of the NSTs. We can also kind of develop with her what's going to work best for how frequently it is we're checking in with her. So we can check in with her every day, we can check in with her once a week. It really just going to depend on what kind of support it is she needs. And this again can also be a discussion with the provider about how frequently they want stats on that patient as well. And then also just being mindful to assess daily fetal movements, and then like you guys already recommended, using the bus or referring to social work for transportation needs. Any questions about this plan of care? Great. All right. 2 days after appointment, the nurse calls the patient for her check-in. She reports her dipstick protein test says 4+. Her blood pressure this morning was 165 over 111, and she's gained 2 pounds since she got weighed at her appointment 2 days ago. She also reports that she woke up with a headache that will not go away after trying to put a heating pad on her neck and taking 650 milligrams of acetaminophen Tylenol. What should the nurse be most concerned for? Yes, eclampsia is on its way, right? So we're definitely into the severe preeclampsia range. So we're definitely on the lookout for the fact that she could have a seizure at any point. So one of the major things to look for in this is definitely know, like if they say, oh, I had a headache that will not go away. It's not gonna be that if you get a headache, it's an immediate sign. What's gonna be is that I tried to get this headache to go and it did not go away. So that is gonna be a major indicator that they're in the realm of severe preeclampsia, and eclampsia is imminent at that point. So please always remember that that headache is really a telltale sign if it will not be relieved by medication especially. So what intervention on the phone will the nurse tell the patient to do?
Call an ambulance.
Potentially call an ambulance, but why are we calling an ambulance? What do we need them to do? Get to the hospital, exactly. So we need them to come in so we can assess them right away. So the provider admits the patient to the labor and delivery unit. The following is reviewed in the chart. Highlight the findings that would require immediate follow-up. So I'll give you guys a minute to look at this, and then we'll go over each section again. Okay. Let's go ahead and look at this together. In our vital sign assessments, what are we concerned about? Blood pressure. Now we're up to 165. How about the urine test?
Very bad.
+4, not good. How about our cardiorespiratory assessment?
+3 is esophageal edema.
And why is that extra concerning now?
It went up plus.
Yeah, so it more than doubled, right? In not even 2 days. So definitely something to concern. How's baby looking?
Just fine.
Status quo, but keeping an eye on him, right? And then what is concerning in our neurologic and musculoskeletal assessment?
Headache and
Deep
DDR.
tendon reflexes with clonus.
With the clonus, yes, because remember, clonus is a very scary sign. So we definitely want to do something about that immediately. And then how do our fluid and nutrition status look? How does it look?
2 pounds in 2 days.
In 2 days. And we said we want to gain how many pounds normally? 1 in a week. So in 2 days is definitely something we're worried about. So now that we've had all of this happening, right? We're in severe preeclampsia, and with that clonus, like Professor Andrews was saying, we want to treat that immediately. So what are we going to start them on? Magnesium sulfate, exactly. So the provider puts in the following medication order: magnesium sulfate, 40 grams IV, and 1,000 ml lactated Ringer's bag via IV pump. The bolus will be 4 grams in 60 minutes, and then it'll continue a maintenance dose of 1 gram per hour. After that, you'll draw your magnesium level every 4 hours, or 4 hours, after the bolus. What will be the rate of the bolus, and what will be the rate of the maintenance dose? So I'm gonna give you guys about 2 minutes to figure out those numbers, and we'll go over them together.
Espresso, yeah. You snooze, you know, I'm about to. I'm halfway.
All right. So what did we get for our bolus rate? 100 mils an hour. Okay, and what did we get for the maintenance rate?
5.
What was it?
25.
25. Good job. All right, so let's talk about the difference between these two. What is the purpose of a bolus?
Get it in
Like
quick.
the loading dose.
Get it in quick. Yep, a loading dose, right? Because if we saw that clonus and we have all those signs and symptoms, we don't want her to have a seizure. So as much as we can get in, as fast as we can get it in, we want that to go first. And then what will the maintenance dose be for?
Keep it at a therapeutic level.
Right, and we see in the order here it says that they want us to do the first 4-hour draw after the bolus dose. You'll continue to draw those levels throughout the therapy of the magnesium, so you want to make sure that you're maintaining that at a therapeutic rate that's actually helping the patient and or not hurting the patient. So if we want to get that bolus dose to them as quickly as we possibly can, what if we wanted to do it over 30 minutes instead of an hour? What would our rate be then?
Wouldn't you just double it?
200.
Yeah, just double it, 200. And then the maintenance would be, if you're doing that.
Well, we're only talking about the bolus. We
So the
wouldn't
maintenance
change the
doesn't
maintenance.
change.
Nope. The maintenance dose will be just as literally it will maintain. It should maintain at a specific level. We don't want to be changing it because then we're not necessarily going to get a therapeutic level. But the bolus we want to get in as fast as possible so that we can safely adjust the rate. Yeah, what was your question gonna be?
So to get it into within 30 minutes, divide the 100 by 2, so it's 50.
Okay, so if we were going at 50 mils an hour, would that take longer or faster than 100 mils an hour?
Wait, am I wrong?
Because if you're going at 100 mils an hour, you're getting more fluid in over an hour. If you're going 50 mils an hour, you're only getting 50 mils in, right? So what we want to do is, I think someone said it over here, we want to double it, right? Because 30 minutes is supposed to take half as long as an hour. So if we want to get it in faster, we want to do 100 plus 100 exactly, so that it can go in twice as fast. What about if I wanted to do it over 20 minutes?
Oh, why don't you calm down?
Come on, you don't want your patient to have a seizure. What are you gonna do?
That's too much.
You guys got this. How many 20-minute segments are there in an hour? 3. So if we wanted to go in 3 times as fast as in 1 hour, how fast would it be? 300, because 100 times 3 is going to be 3 times as fast an hour as it would be if you did it over 1 hour.
Hey, come on, man, I got math on these.
Yeah. So the reason I went over this is because you will likely see this test question and one very similar to it on your test. It's very important to know for that purpose, but also again in real life, just thinking like, how am I getting this to my patient as therapeutically and fast as possible? And that will include some level of med calculation. So just really make sure that you guys do these practice problems. There are some, I believe, on Blackboard, and then there were some others in the PowerPoint in addition to this case study that's on Blackboard as well. You hear it, go ahead.
So whenever if it has us doing 20 minutes, that's gonna be multiplied by 3, basically, whatever our value would have been. So,
Whatever our mils per hour is, whatever our rate is, correct.
okay, thank you.
Did you have another question?
Yes.
Mhm.
When I was like just watching the video lecture,
Yeah.
I was just wondering why we don't subtract the bolus dose when calculating the maintenance dose, and then with that, is it the same bag, I guess, and you just change the rate, or is it like the bolus and then like you have like a new bag for the maintenance?
That's
It's a really good question. So I think I remember you saying that typically the bolus bag will be separate from the maintenance bag.
Yes.
But overall, they're different doses, right? So you are getting a mass dose at the beginning. So then we want to maintain that. So we want to flood their system with it, and then we want that to maintain through them, right? Because we want to get all the effects of it as fast as we can, but we don't want those effects to wear off. So that's why it doesn't necessarily like subtract from the maintenance dose, because the maintenance dose is actually supporting and maintaining the bolus dose that they got. But in terms of it actually coming from the bag, I think they are separate bags.
Yeah, they're totally separate bags. Like when you're doing mag bolus, it's either 4 grams or 6 grams. So are you grabbing the 4 gram bag or the 6 gram bag? And then your maintenance is like a bigger one, because that's maintaining that therapeutic level. And I know you guys thought that those additional questions were tricky, but that's what we seriously do at the clinical setting. We would never give a bolus in an hour. I would not want for it to take an hour for my patient to get therapeutic. If they are gonna seize, I need treatment ASAP. So we're honestly doing it in 20 minutes. So on a test question, like Crystal said, you have to read so careful, because I'll say, what would be the bolus rate if you needed to infuse in 20 minutes? So then that means you're gonna have to say, okay, well, what's my rate if it's hourly? Okay, and 20 minutes goes into an hour 3 times, so 3 times my hourly rate is this.
Okay, that's easy.
So you're gonna have to read careful and just understand that that's really what we do in the clinical setting. And you guys haven't had a dosage test in my class, so this is where dosage comes in. So woohoo!
We have another question over here?
Is there any reason why you couldn't use the same bag to do the bolus and then infuse the rate afterward?
There would be no reason, but we just have a bolus bag and
But you have the
and a
bolus
maintenance
bag,
bag.
okay.
Because the bolus bag is like tiny, it's like I don't know, like a tiny little bolus bag, and then the maintenance is a lot bigger.
Okay.
So I guess it would be because if we're having that fast bolus rate, what if someone plugged something in wrong and they accidentally gave the whole bag at that big rate? I don't know, I'm just.
Or they forgot to put in a volume to be infused.
Or, yeah, so it's just, you know.
Okay. And then, well, I mean, you probably wouldn't do it anyway, but we were wondering, like, if you hang a drug for a bolus dose that then has a maintenance dose afterwards, is there a way to program the IV pump to change rates after a certain
It's a
period of
great
time?
question.
Or do they want you to have to go in and change it to check on the patient, was what we're wondering.
That's a fantastic question. So since magnesium can depress the central nervous system, during a bolus, we are not allowed to leave their bedside.
Oh, wow.
We are, yeah, and
Need
it
a
goes
hybrid
in,
drug.
if I just said it goes in 20 minutes, you're just chilling there for 20 minutes documenting. When these patients are having severe preeclampsia, we have a lot to do. So to stay in there for 20 minutes to document is not a long time. And then by the time we finally get done documenting and doing our every 5-minute assessments, then we'll hang that maintenance bag and change that rate. Good question.
Yeah, those are awesome questions. Alright, so after administering the bolus at 1200, the nurse draws a magnesium level at 1600. The following assessments and test findings are recorded. Highlight the abnormal findings. So take a little bit of time to read over this. Alright, and our vital sign assessment line. What are we concerned about?
Maybe with BP, but
The blood
it's
pressure,
coming back down.
but it is.
It's coming down, but is it still higher than we want it?
Mild.
Yeah, so we're still
Yeah.
keeping an eye on that. And then how about that magnesium level? Is it where we want it? No, so it's subtherapeutic. And how about our intake and output over the last 4 hours? How's that?
Output's a little low.
Okay, what's making us say it's a little too low?
Because it says
It'll wait.
1200 to
No, it's fine.
So it's over 4 hours.
200 mLs per
They
hour.
got a liter. Say that again, sorry.
It's 200 mLs per hour, which is like way more than, it's actually, it's good.
It's good?
Very high.
Okay, so how many mils per hour do we want them putting out? Or mils per hour?
30
How many mils do we want? Yeah, putting
30
that.
mils per hour.
Yeah, 30 mils per hour, exactly. So If over 4 hours they put out significantly more than under 20, right, then they're good to go. It is a little bit less than what they got in, which was a liter, but they're gonna retain some of it. It's not, they don't necessarily have to put it all out, and people pee at different times and things. How are the DTRs looking?
No
Still
way
has
now.
bonus.
We're still where we were, right? So we haven't improved yet. And then how's baby looking?
Minimal variability.
Is that good, bad?
That's
Not good. We don't
Not
good.
good. Why do we think baby might have a little bit of minimal variability? The magnesium, what is the magnesium doing?
Oh, it's a depressant.
It's a CNS depressant, exactly. So baby's gonna be a little more relaxed in there. So we definitely wanna keep an eye on them, and that's why, like Professor Andrews was saying, they will always be monitored consistently during that time, both mom and baby. So, because our mag wasn't very helpful, the provider put in new orders for a maintenance dose of 2.5 grams per hour. What is the new rate? Yeah. Oh, sorry, you were answering. That's okay. I was gonna give everyone, I thought you had a question. I was gonna give everyone a little more time. No, but you were right. I don't know if everybody heard her or not. I'll give everyone that's still calculating a little bit of time just to work it out.
I didn't even get my calculator out yet.
Oh, okay. I'm actually still recording. Yes, so the answer was 62.5 for those of you who called it out. And if you guys do have questions and struggle with that at all, please always feel free to come and ask us questions, because like Professor Wraith was saying, that's really important to know, both for testing purposes and for in real life clinicals. So by all means, there are plenty of practice questions. If you have questions about those before the test, please feel free to ask about that. After increasing the mag dose to 2.5 grams at 1700, the magnesium level is rechecked at 2300. The following assessments and test findings are recorded below. Highlight the abnormal findings. I'll give you guys a minute here. All right, what in our vital signs is concerning? The respirations, and then what else is it concerning? The oxygen, right, yeah. Definitely the respirations and the oxygen. What about our magnesium level? Where are we? Super therapeutic. And then how does our output look? It's too low. What did we need it to be in the last 4 hours at least?
Want it at least to be 120.
We want it to be at least be 120 because we said how many mils per hour? 30, yep, so 30 times 4 would be 120, perfect. And then how about our DTRs?
They're absent.
They are not there. Is that good?
No.
No, it is not good. And then how's baby looking?
Still minimal variability.
Still minimal variability. So now mom is a little too depressed, significantly depressed, and then so is baby. And this is actually the last slide. So what is our priority nursing intervention? Turn it off. Yeah, so we said turn it off. You want to immediately stop whatever it is that's causing that. And then what was the next thing we said? I heard it up there? Calcium gluconate. You always want it at the bedside. So let's say we give that calcium gluconate. What do we have to watch for now? Seizures, exactly. So all that hard work we just did to try to prevent the seizures, we just reversed it all. But it was important in this scenario, correct? Because we were seeing her starting to struggle to breathe and maintain her oxygen. So that's definitely going to take priority in that moment. And as I'm sure you've noticed in your other clinicals too, medicine's always going to be a risk versus benefit gain, right? So we might have to stop that for right now, but we're going to need to make sure we keep an eye on her all the time so that we can make sure she's not going back into preeclampsia and that she's not going to have a seizure. Mm-hmm.
So with the calcium gluconate, you said that it's always at bedside. So
When you're starting MAG, right?
So obviously, like if you're doing like blood levels, those take time to come back. So would the order for that be written like if respiratory rate gets below whatever? Like what is?
That's a really good question, yeah. So basically it's gonna say if you have some level of symptoms of hypermagnesemia, you're right, we're not gonna wait for that level to come back. Like, yes, we are titrating the drip to that level, but that's why we're doing those assessments every 15 minutes, and a lot of times we're not even leaving the room. So that's a really good question. But it will say in there to give it for signs and symptoms of hypermagnesemia. Yeah.
And you can leave the room for maintenance,
Oh, for
just
maintenance.
not
Yep.
bolus.
Yeah. Thank you.
But yeah, because labs are every 4 hours. So if we notice they're slurring their speech, they're drooling, DTRs are absent, we don't need a mag level to tell us they're toxic.
You can do the calcium gluconate.
Oh yeah, stop the mag, give the calcium.
Okay.
It's scary when it actually happens.
Awesome. Good work, guys. Do you guys have any more questions before we take our break? Or you can save them before we come back, either way. Great. So we'll have another activity. Go ahead and take a 5-minute break.